today we're actually going to host this ourselves. And we thought that trauma, which has been ubiquitous still throughout this COVID and COVID pandemic induced restriction, still has been a major challenge for us. So we're talking about thoracolumbar fractures today and some controversies with some worst case scenarios. And it's going to be presented by our faculty, including myself, and our wonderful fellows, and we'll ask them all to introduce themselves as they speak. So one of the key things of this part, and we'll probably have a part two because there's so much to say about thoracolumbar fractures, is to discuss what really matters in our assessments and to review the boundaries of treatment also and how we can kind of try to cheat the situation in the favor of our patients. So timing of surgery we'll not be able to discuss by today, but anterior, posterior, the mechanical aspects will be a significant part of this. And obviously, we'd like to really try to avoid having patients decline neurologically, and we want to optimize the neurologic status. So indications for surgery, critical timing, and best approaches are the main factors here. And again, right here, we'll come up to a question, and I'll ask Dr. McBride to maybe come up front and sit in Dr. Oskuyen's spot, because Dr. Oskuyen is on spring break, and he's skiing right now, and see whether that microphone's activated. And Paul, I know you're from upstate New York, but you're now in Florida. You've lost your skiing skills. So this is, God forbid, you and you're skiing with Rod. And just let me tell you, skiing with Rod Oskuyen is not a good idea. He's kind of a little bit of a dangerous skier. And God forbid this is you. This is a T12. Assume this is the T12 level. There are no tricks here. Burst fracture. So the question that I'll have for you is, you've made the mistake of skiing with Rod Oskuyen, and this is your injury. You're fortunately neurologically intact. You hurt like heck. And what are some of the key things that you want to be looked at as you're in the ER? You're neurologically truly intact. There's no trick there. But what do you expect the ER doctor to do for you?
Well, I want to, have my pain controlled first, after being made sure that I was neurologically okay. I'd want the ER doctor to make sure I was able to, void completely by checking post-void residuals. And then with a fracture like this, I would like to evaluate the fracture with some axial loading on the spine, standing up, to see what the fracture looks like under some weight.
So a priori, would you lean towards wanting to have surgery? Because you're a very active young man and you have a vigorous surgical practice. You have a young child at home. Would you want to tend towards surgery or not?
I think if my goal was getting up and back to my baseline functioning as fast as possible, I think surgery would be the way to do that.
Okay, so surgery. Dr. Hayumi, you don't have a microphone on you, but what's your preference? Would you want to have surgery done to try to get up and going again, or? You'd be leaned towards surgery. Okay. Perry? Surgery. My conclusions don't go skiing with Dr. Oskuyen, but that's a different story. So we have so far 3 in favor of surgery. Rick, surgery, no surgery? Dr. Elias, surgery, no surgery? I know you came a little bit late, so you don't know all the technical details. It's all there. Skiing with Dr. Oskuyen is a bad idea. Okay, Zach, come on, be a critical Canadian here. How's the patient? Well, has pain, and this is a great question. So you did give a very good physical exam, request neurologic exam, voiding, etc. There's one thing in the physical exam that is really important. Paul, what's that? For a thoracolumbar fracture especially. What's a classic prerequisite in the ER as somebody arrives on a stretcher, as you get called to evaluate the patient? One of the first things is a guess what I'm thinking question, but it's an important one.
Yeah, I don't know what you're thinking.
What are we doing when a patient arrives? I'm trying to lead you here supine on a stretcher, and you're called to see the patient. And you've had the first interactions, seeing how they do, moving.
They ambulate?
No. You roll the patient, right? Do you do it in Tampa?
Yeah.
We roll the patient, 3-4 people, proper roll, and you palpate occiput to coccyx. And why is that relevant for this?
Can localize the pain to that level.
So there's a very distinct physical exam thing that you want to elicit in a case like this.
you can feel
focal pain, and a gap, ecchymosis, crepitus. That's the key thing. Right at that, I don't have a cursor that works here right now, right at that junction zone where that fracture is. So that's a key physical exam thing. So Bob, just going back, this is skiing with Dr. Scuy, and I highly recommend against it. The literally unanimous opinion of our fellows was if this was their spine, their own spine, just because their dedication to the fellowship, they'd want to have surgery to return back to the operating room, to your clinic faster. If this is you, you're neurologically totally intact, single system injury, the noggins, the head is fine. Would you?
This looks like it's operative every other week, but you already showed the next slide.
Yeah, no, it's we're going into classifications quickly.
I would not operate in order to get back to the clinic, but I would operate.
You would operate to get back to operating.
The motivation is wrong, but the need for the operation is correct.
All right. So we have a literally unanimous, ladies and gentlemen, this is pretty rare in our field, decision for surgery. One of the classic problems is how to classify this. Obviously, this is an AO spine teaching facility, so we are very much in the AO spine paradigm. And if we talk about this fracture, is this an A, B, or C? Paul, do you want to just venture the general letter nomenclature? Is this an A, B, or C?
That looks like a C.
That would be a C probably. But this is, again, one of those things, we have so many different languages, and it's really problematic. And again, whilst they never should be dogma, it does help understanding checklist function, direct treatment. So that's a big deal. And we'll quickly delve into the severity scales. But this is one of the problems of the original AO classification. There were so many subtypes, just even for the A's, that it became very confusing and very problematic for everybody. So this is just was a little bit too much, although it's very comprehensive. So we should use classifications to help us understand our injuries better, communicate better, predict treatment, and hopefully enhance our research efforts. And again, this is the situation that I was just inferring to. We should have a very consistent approach towards patients, away from intuitive medicine, obviously beyond empirical medicine into precision medicine. What's going on with this patient? And again, having more sophisticated models, and we're the ultimate computer that imputes these models. And we're kind of still in this phase of early classification, empirical medicine. So this is where we are. And again, one of the key things that we want to determine is stability and neurology. And you inferred both of those, Paul. You're on the hot seat very well. And for spine fractures, for thoracolumbar fractures, one of the key determinants is this model of White and Punjabi's, the instability or stability process. And this is the best definition that has ever been written. There are no numbers in there, but it has a lot of decision-making and assessment in there. And I think it was Dr. Hayumi who gave a very nice presentation on these fundamentals in spine care. So a spinal column should be able to tolerate physiologic loads without undue pain or neurologic deficits being added. And this is so eminent for this whole discussion. So what really matters for these fractures, and we're going to have some great cases. I think we'll have Dr. Hayumi present a case. Dr. Elias, you'll have a case. Dr. Nuna and Rick, do you have a case? Yeah, good. So we'll go through those, and always we'll kind of go through the anatomy, biology, mechanism, and all that. One thing I want to briefly talk about is, again, the spine trauma study group, and this was the great Alex Vaccaro's brainchild, but he put together a great group of people. And this basically condensed things down, and I just want to go through those briefly as we're getting ready for the cases. I want to look at the injury morphology, neurology, and ligamentous integrity. And this is what Dr. McBride was put on the hot seat for before, this posterior ligamentous band. So structural damage is intuitively clear. Our ventral column, there are no two columns in the front. We should really bury this concept. Dr. Hart, are you in agreement? 3 columns out on the thoracolumbar spine? So structural damage is a substantial thing, and again, identifying where the problems are, and this is obviously a highly unstable anterior column. The weight-bearing column is highly deficient. Neurologic status, and again, this is separated into intact nerve injuries, cauda equina, and cord injuries, specifically separated into incomplete and completes. Now, this is the key thing, the PLC, the posterior ligamentous complex. And I think of all the things, this is one of the main contributions of the spine trauma study group. This, for the first time, really identified the integral part of the posterior column being a tension band that is so important in terms of maintaining, like an outrigger cable for a crane, the straight aspect of our spine. And again, on the top right, you see a case in surgery where we had a disrupted PLC from trauma. The artist's rendition on the right side just illustrates the interspinous ligament being truly torn. The facet capsules, just on seeing the bottom right side, can be injured as well. And much has been done about MRI scans and what MRI scan means, what in terms of injuries. This is still something that we sometimes struggle with, but it's certainly a necessary and helpful thing to look at if we are in doubt about posterior ligamentous disruptions, and if the CT scan and our physical examination with palpation doesn't identify that. And this is obviously a highly unstable posterior tension band disruption. And kyphosis, as the spine tilts forwards, can have two underlying pathomechanisms. It can be pure ligamentous, such as I showed right there. It can be more bony, where the bony elements in the back just splay apart, and there can be a mixture of both. So the other thing, and this is something that has really become an increasing focus now being revisited, is the more kyphosis we have, the more kyphotic forces are exerted upon the spine. So having an intact ventral column in balance with an intact posterior column is absolutely important. And so this is just a case and example of a significant kyphosis. And the question here is the PLC intact? You see the question mark up there on the sagittal image. And you see the angles that we faithfully measure. And in this case, a MRI scan is rather illustrative. It does show the injury. At this point in time, I think we can all agree that both a CT scan and, if in question, an MRI scan are still essential for the assessment. Now, I wanted to show just one slide of a previous research project that we did at Harborview, the so-called PLL, the posterior longitudinal ligament, the coating of the posterior vertebral body. Why has this been such a big focus? Because a lot of people think that ligamentotaxis, the stretching of a broken bone that then reduces through ligaments, can help in realigning burst fractures. And this is an actual picture of one of our projects that we did there. It's an anatomic discussion of the PLL, and it's actually a really thin ligamentous structure. And you can see that it's actually not even attached to the posterior vertebral bodies, but it's actually attached through the discovertebral junctions at each level. So the thick part is over the disc areas. So we've actually renamed that internally the puny little ligament. But the PLL does not have an actual capacity in a burst fracture where it'll be usually torn. So you can't distract a thoracic and a lumbar spine fracture and think that the PLL will reduce those retropost fractures. That's not going to happen. It's going to be torn. The strength of the ligamentous construct is truly in these disco-ligamentous attachments that maintain the nucleus in its proper position. You can see it on the left-hand side on that right histology slide by Dr. Rauschnig. So this is, again, and I'm going to flash it very rapidly and then get out of there. This was the main triad of assessment of the spine trauma study group, injury morphology, and then you go through posterior ligamentous complex assessment, and then you look at neurology of the patients. And again, the point scales have been very heavily discussed and are probably to be taken with some grain of salt. But basically, if you have a translation, rotation, or distraction injuries, you get a high point number. If it's a pure burst fracture, it's just a single point. If the PLC is disrupted or suspected to be disrupted, you either give 3 or 2 points. And again, MRIs, whatever you can think of, upright x-rays, physical exam, are all legit. And then we have neurology with various point scales attached. And interestingly, incomplete patients have a higher point scale than complete patients. And then you assign points. And again, the thought was that at around 3 points or up to 3 points, you can probably safely treat a patient non-surgically. Once you're in that 4-point range, you probably want to think about surgery, but it's kind of a gray zone. And above that, it's a pretty clear surgery. So remember your spine fracture, all of you actually decided for surgery, and all of you were motivated, except for Dr. Hart, who did not want to go back to clinic, but wanted to operate, that this would get you back to work faster. And I commend you on that, all of you. Lee, would you have surgery if this was your fracture? You're neurologically intact? Lee does all of our technical work. You walk it off. Lee has no trust in our skills. If we actually use the spine trauma study group scale, we actually come up with a points scale of 3. And the patient's posterior exam was innocuous. So there's no gap, there's no ecchymosis, there's no crepitus. Patient did not get an MRI scan. And this patient was actually treated. She was 38 with a hyperextension cast in those days and had a very nice re-expansion, actually held in that position. What classifications don't give us, and this is where we're going to segue into some of the case presentations from our great fellows, is the patient health status. And this is something that all of our classification systems have still struggled with quite a bit, how emaciated they are, how large they are, because again, this patient that you just saw was very fit and thin. And again, age doesn't matter anymore because we have patients who are in their 90s and ascend Mount Everest without problems. And some lifestyle choices are less commensurate than others towards bone healing, Gesundheit. And there are people who just defy anything in terms of surgery even, and make it very, very challenging to come up with a treatment plan. So I'm going to stop here and we'll resume after some of the case presentations. And Dr. Hayumi, do you want to come first? So all of these cases that are going to be shown are not just pure trauma cases. They're all from last week. I'm going to don my mask here, although all of us have been immunized. All of them have a twist on the oncologic or infection side, but they're all fractures in the thoracolumbar junction and all treated within the last week. So Dr. Hayumi, please introduce yourself.
Absolutely.
All right. Good morning, everyone. My name is Puriya Gayomi. I'm one of the spine fellows here at Swedish Neuroscience Institute. This was a case that we did last week on Saturday. So this is a case of a 31-year-old gentleman with history of IV drug use and hepatitis C who presented to one of our emergency rooms in the Swedish system with about 2 to 3 weeks of worsening back pain. He injects daily meth and heroin. He smokes a pack a day. He is marginally housed. He has he lives with his girlfriend. He was in the emergency room. He was febrile. His CRP was 190, ESR was 84, and the blood cultures that he obtained in the emergency room at the time eventually grew out MRSA. He denied any bowel or bladder incontinence, and on exam, he also denied any kind of neurological symptoms in his lower extremities. His physical examination, as you can see, his motor exam was completely normal. He was hyperreflexive to his Achilles reflex. Other than that, he really didn't have any other significant findings on his exam. His sensory and motor exam were completely benign. These were the images that were obtained. As you can see, he had complete destruction of the 3 columns of his T8 with surrounding, which what appears to be a phlegmon or abscess that extends into the chest cavity. He had significant focal kyphosis at that level, at about 40 degrees of kyphosis from T7 to T9. And on the CT scan, you can see better that he had involvement of the end plates of his T7 and T9 as well. Since this is a trauma talk, I know this is not trauma per se, but based on the amount of kyphosis, I mean this, and if we look at the load sharing classification, just the kyphosis and the vertebral body comminution, this would put him in the category for anterior support. And we ended up taking him to the operating room. He underwent T3 to T11. Posterior spinal fusion with T8 corpectomy, irrigation debridement. Surprisingly, no purulence was noted at all during this procedure, but there was a significant amount of necrotic and kind of chronically infected looking tissue and bone that was debrided. These are the CT scans post-operatively. As you can see, we corrected the kyphosis nicely. He was, I believe, just discharged. Obviously, infectious disease was consulted post-operatively. They recommended 6 weeks of IV antibiotics. His TT and TEE were both negative. Addiction recovery consultation was made during his inpatient stay, and he was recovering well. In terms of the literature search, this was a study that was done at Harborview. They had retrospective 128 patients with epidural abscesses. 51 were treated with antibiotics only, 77 of them with surgery and antibiotics. And the results that the majority of these are in the lumbar area, about 40% in the thoracic. Average involvement in this study was about 3 levels. And the risk factors for epidural abscesses were IV drug use, most importantly, followed by diabetes, and surprisingly, people with no risk factors. Pathogens, MSSA, followed by, it's supposed to be MRSA. And predictors of medical failure are people with diabetes, CRP of more than 115, elevated white count, and positive blood cultures. And these were additive. So people with more than 3 of these risk factors had about almost 80% risk of failure with medical treatment only. And they also found that people with early surgery with epidural abscesses had better neurological outcomes.
Puriya, before you leave that slide, would you comment on the first line of data there, the 55%, 39, and 35%? That adds up to over 100%. And I think there's a very legitimate reason for that. And that affects why we do the workups we do. So can you comment on that?
I didn't catch that, but that's a really good point. And I'm assuming it's because of the junctional levels or but I'm not sure why that goes to more than 100%.
Have you ever seen a patient with 2 abscesses?
That's right.
Yeah.
Yes.
This is why we do the pan spine MRI.
Full MRI, absolutely.
Can you go back to the initial slide? So we all realize we're not talking about infections primarily here, but the point of stability is a really big one. And we've just seen that pathologic conditions of the spine can mimic trauma, and the spine can fail even under low loads due to underlying disease processes. So if you applied the lessons of the spine trauma study group, assuming that they're correct in here, how would you rate this from a morphology, from a PLC integrity, and from a neurologic perspective?
So on his MRI, I didn't show all the slides, but there was definitely involvement of the posterior elements in him. So this would be at the very least a B classification from an AO classification standpoint. And this is an unstable, if we call it a fracture or unstable injury of sorts. I did not show there were no standing x-rays. He was taken to the operative pretty emergently. But given the amount of kyphosis, the amount of comminution, and the disruption of the posterior elements, this is absolutely an unstable injury to the spine.
So from what I asked was the spine trauma study group. The morphology is that the ventral vertebral column is very badly disrupted. It's basically not weight bearing, capable of weight bearing. Mm-hmm. So that would be 3 points probably right there. That puts the patient on the margin of surgery.
That's right. Yeah.
Neurologically, was the patient intact?
Intact. Yeah. Examination.
And then you said that the PLC was disrupted. On that MRI scan, can you use your cursor? I know I struggled with that before. I don't have that special light feature. There's a bright signal somewhere. Did you actually find the PLC to be torn? You're in on the surgery, right?
It was torn, definitely, 100%.
So how can that be? The patient was up and around and moving. There was no actual known trauma history from a major event.
No, so he had progressive back pain to the point that he wasn't able to ambulate, and that's the reason he called 911 to come in. But that just, I think the infection basically spreading posteriorly into the posterior elements, and there was clear disruption of the posterior elements intraoperatively.
So using this simple 3-point scale, this patient does get into a surgical terrain pretty rapidly. Classically, I was at least trained, I don't know how Dr. Hart trained his fellows and residents at OHSU. If you have a patient who's unable to bear weight and be up and around, you usually want to lean towards surgery. But a neurologically intact patient with infection, we classically treated with a brace and antibiotics and not with surgery. So, Bob, stability-wise, how does this apply? How do the lessons of trauma care apply to this infection patient?
Well, I think the biggest part of the pathology here is the collapse of the anterior column. And even though this patient doesn't have neurology on appearance, on admission, if you look at that sagittal MRI at the in the upper column there, or upper row, there's clearly cord compression. So the risk of progressive or development of neurologic compromise is very real in this patient. So I think the mechanical situation here, it's basically the loss of the anterior column, and the posterior ligamentous complex I suspect was maybe just lax. It may have been dissolved as a result of the infection. Hard to imagine it as a result of high energy trauma here. In most cases, if you have an intact posterior ligamentous column, you're going to have sufficient stability in an acute fracture to treat it non-operatively in most cases. I think this is maybe a slight difference between infection and trauma, in that in trauma, the anterior column is only going to progressively stiffen, right, as the fracture heals. Here, it's going to progressively worsen and dissolve. And so you're really obligated, I think, on the basis of the anterior column here to intervene. Yeah.
So in terms of hardware and infections, Purya, there's a lot of concern always by our infectious disease colleagues, and I know this goes beyond the thoracolumbar fractures, on putting hardware into an infected terrain. How do you answer that concern?
So the way I was taught, I know in orthopedics, it's a big no-no to put any kind of hardware, especially in the joints world. But in spine, one of the big causes of infection, or at least progression of infection, is actually instability. And to get rid of infection, obviously you want to irrigate and debride the source of infection, but instability will prevent healing and actually possibly lead to worsening of that infection. So I know in the spine world, it's common practice to place hardware as actually part of treatment of eradicating the infection. But I know there's a lot of pushback, especially here.
So one of the big concepts is stability and battling infections, and musculoskeletal infections are supported by instability. This micromotion induces bradykinin and cytokine releases that favor bacterial growth and enhance necrosis. So having a stable, mechanically realigned spine is actually helpful in this regard. Plus, titanium has less susceptibility towards fostering staph, at least that's been shown, than stainless steel. So this old paradigm of hardware is bad for infections is actually an anachronism, and we need to actively work against that. So you had no problems with the patient? The patient did okay?
The patient did great.
Did very well.
Yeah,
are you bracing this patient?
We did not brace the patient post-op.
Was your bony purchase okay?
Yeah, it was just a slight subsidence into the inferior end plate, but that was expected. Looking at the pre-op CT, that end plate is not intact of T9, but.
So it looks beautiful. And going forward again, address the number of levels that you and your attending, that was Dr. Oskuyan?
No, Dr. Oskuyan.
Yeah, address the number of levels that you chose to.
So plan was 3 above and 3 below, but with the upper vertebral body, he just thought that the purchase wasn't as great as he wanted it to be, and we decided to go 2 more levels above in the proximal and to T3.
Where does this 3 above, 3 below come from? Do you know?
I don't know.
Dr. Hart, can you help us?
I think that comes from years of hard-won experience.
I think that's right. I mean, it basically came out of the old Harrington rod lessons and then Edwards rods, where we basically could create a cantilever effect posteriorly by having a hook claw construct. And by offloading the vertebra immediate to the burst segment, you basically then rely on 2 vertebrae adjacent to that partner level, more or less, that adjacent level, to basically offload the construct. So this is where the 3 above, 3 below came from. In the thoracic spine, not a big deal. In the lumbar spine, this becomes a much bigger deal, which I think is a great segue to Dr. Elias. Thank you, Purya. Nice presentation.
Appreciate it.
And Lee, Dr. Elias needs help. Dr. Elias is from Beirut, Lebanon, and he's just figuring out the connectivity. And again, from last week, he's selected a case that shows principles of thoracolumbar stability.
So good morning. What's the problem on this? Okay.
Excellent.
Thanks, Lee. So good morning. My name is Elias. I'm one of the spine fellows here at Swedish. Today, I will present this case that we did last week with Dr. Chapman and Dr. Oskoyan. So I have this patient. He's 71, male. He's a retired physician. He has a history of ankylosing spondylitis. He came with 2-month history of low back pain, non-radiating. And he remembers that he fell down from a ladder from a 15 to 20 feet height. So he presented to Swedish with a pain that is mainly dull in nature, 4/10, mainly aching midline. And as I said, it was non-radiating. It was worse when he's standing or sitting, and better when he's lying down flat. And he noticed that he has a progressive forward curvature, or like he's leaning more forward over the last 2 months. So on exam, his motor power was 5/5 all over. He had an X-ray 2 months prior to presentation when he fell down. And it was read that he had a mild compression fracture over the L1 area. And otherwise, he was clear to go. So if you can see here, this is the L1 area. So this one was read as a mild compression fracture and nothing else to be done, and he can go.
So the patient was basically sent home?
So patient was sent home with reassurance and some pain medications. However, as I said, the patient didn't do well. His pain was consistent, and he was leaning forward. So he presented to us, and we did a CT scan on him.
So he was how far out now?
2 months.
So he's a practicing physician, and he basically fell from a height of about 15 to 20 feet, trimming his own tree in his property, had severe pain afterwards, but no neurology, had an electric shock as he impacted.
Yeah.
And what's wrong with his spine in general?
So this patient has, as I said, history of ankylosing spondylitis, and you can see it here also on thoracic and lumbar CT. And he has 37-degree kyphosis. And as you can see here, just let me put the highlighter again. So he has a T12, like 50% fracture, L1, more than 80% burst fracture, and he has a retropulsion over L1, over the L1 area.
So he has ankylosing spondylitis. He has a
he has ankylosing
12 L1 fracture. Now going back to that original picture.
Yeah, the X-ray, you mean?
Yeah, the X-ray.
This is the X-ray.
Yeah. So in a hypothetical parallel universe world, what should have been done differently? This patient shows up in an ER. He's just fallen from a height.
Yeah.
He's neurologically intact. He's an extremely stoic individual. What should have been done?
So this patient, first of all, he's 71. There is possibility to be osteoporotic, even without doing the X-ray or CTs or having the history taken. And on top of that, he has ankylosing spondylitis. So I don't see any role for X-ray in this patient. We should directly go for CT scan for the thoracolumbar area.
So you want to get a CT scan?
Yeah.
What's one of the classic mistakes of getting plain films in the setting of thoracolumbar trauma?
So if you take an X-ray for the thoracolumbar area, mainly the T12L1 or T11L1 will be masked because of the placement of the ribs and the rotation of the junction over here. So mainly the fracture here are missed, especially at this level.
So let me clarify that a little bit. So lumbar spine X-rays, we usually order thoracic and lumbar X-rays.
Yeah.
A thoracic X-ray is centered on what level?
Maybe T6.
T6. And a lumbar X-ray is centered on what level?
L3, L4.
L3.
Yeah.
So what happens in that junction zone? If you put that red cursor onto L3, because that's the X-ray beam that's shooting right through there. What happens at the thoracolumbar junction? You get what phenomenon? It's called parallax.
Yeah, so we get less details over the junction and more details
it distorts the junctional zones.
Yeah.
So you get a distortion phenomenon. So that's a real problem. The main problem that I saw is not that a CT wasn't obtained, which I totally agree with. The main problem that I saw is that there was no documented physical exam. Nobody seemed to examine him in that ER, which was not one of our ERs, in full defense.
Yeah.
I know I'm sounding defensive here, but there was no palpation of the posterior midline. There was no assessment of past medical history and ankylosing spondylitis.
True.
All right. So moderate compression fractures. Do we know that they're compression fractures at this point in time? You said compression fractures.
Yeah, so the report said he has some scoliosis and mild compression fracture. That's it.
So you just used
and
the
they sent him,
terminology.
yes, no, they only said moderate compression fracture, nothing else. This is a copy paste from the report.
Okay, so now let's move forward. So Dr. Hart, do you want to bring the microphone to somebody else? The question is now, what do we do here? The patient is neurologically still intact. Do you have an MRI scan also?
So I have an MRI scan.
And a physical exam?
So
Who do you want to torture?
I think Paul's on the hot seat here.
Paul's on the hot seat again. Boy, Paul, you're a popular target. So tell us what you're seeing here, Paul.
So the MRI does show again that T12 and L1 burst type fractures worse at L1. Does show again the kind of retrolisthesis of the L1 vertebral body with some narrowing there. I have to look at the axials, but it does look at least moderate. It does look like the kyphosis reduces a pretty good deal, laying flat in an MRI scanner. And it looks like there may be some signal in the posterior ligamentous complex, some hyperintensity just under the spinous process of what looks like T12. So what is your assessment? When you see this sagittal MRI especially, what's your first thought when you see this kind of a quagmire? Neurologically speaking, okay, I need to give you more hints. Go through that sagittal. This is a problem, right? So where's the conus? The conus is right at the level of the fracture where it's most stenotic.
So this is something that we basically want to immediately look at. So post-void residuals, probably do a rectal exam, very carefully go through a reflex exam, which again, all together was remarkably normal. So no issues there. The kidneys had a very large cyst on the right side and a ureter cyst on the left side. So, but he had a pretty much normal urinary function. So we proceed from there. What do you want to do now, Paul? What is your treatment recommendation? This patient actually walked into clinic with a significant gibbous. What do you want to tell the patient needs to be done?
This patient undoubtedly needs surgery. So I would strongly recommend and push for surgery despite him walking in. I would tell him that he has a high risk of neurologic deterioration, especially in the setting of ankylosing spondylitis with that long thoracic lever arm. I would strongly recommend surgery, and given his AS, I would tend to place a longer construct.
So Dr. David joined us. He's a well-known interventionalist. And can you go back to the CT scan? I'm going to take the microphone over to Dr. Glenn David. Glenn, go back again. Go back to the CT. Yeah. You get asked all the time, can you put cement in there? This patient actually is a physician colleague, said, can't you cement this? Because when we started talking about surgery, like Dr. McBride said, his eyes got pretty big. What are the boundaries of cementing?
Sure. So I look at what looks to be a T12 there. You have an L1. Looking at T12, first of all, though, looking at the inferior end plate, doesn't look like it's intact at all. If I were to access a T12, I would go superiorly and in the meat of that area just below the superior end plate. So some cement can be put there, but not very much at all. Looking at the L1 fracture there, just a kind of sliver left of the vertebral body. But there is some cement that can be put there, but it's going to be quite unstable and quite quite compressed. So a high degree of leakage would most likely occur.
So that was our assessment also. So he basically said, sorry, I'm not even going to ask you or Dr. Wukong, who is also online here right now. This is beyond cementing. Ankylosing spondylitis fractures in the beginning of their fractures, before they collapse, are they suitable for cementing, or are you more worried about those patients?
Definitely more worried because of the instability occurring in these patients.
All right, Elias, take us forward to the classification slides that you put together.
So today Dr. Chapman was talking about the classifications. So this patient can be classified now as type C or translation type fracture. Most likely he didn't present as type C, he presented maybe as type A4 or maybe A3. Initially 2 months ago. And for the TLEX, so this patient has a distraction or a translation fracture, which is 3 points, possible integrity of possible PLC rupture also, which is 2 points, which makes the patient surgical. Because everything above 4 points in TLEX is surgical for the patients. So we elected to do surgery for this patient. And we did T9 to L3 instrumented fusion with L1 corpectomy and cage insertion.
Now, so Bob, we put this cage in, Dr. Osgood and I did this together. The cage in its sagittal alignment was planted kind of in an oblique fashion because that's how the cage nested. Is this a problem? I mean, obviously we want to have a straight cage in a sagittal plane.
Yeah, I mean, we talk about X-ray hygiene at times. So you look at that as a surgeon and you kind of wince looking at it. But I think from a mechanical standpoint and an anatomic standpoint, it's going to be just fine. So it's well out of the canal. It's the end plates of the cage are clearly well expanded, well embedded into the end plates of the vertebra above and below. And if you look at the end plates themselves, and particularly the end plate of the upper vertebrae, this is going to be hard to get the cages nested parallel because the damage to the superior end plate or the inferior end plate of the superior vertebra is just so severe. It's going to kind of collapse in there. So with this amount of posterior fixation, I have no concerns looking at this, and I would have accepted it myself if it becomes in a situation where you're going to do more damage and you're not going to improve your X-ray by reducing the cage and try to reposition it. So I think it's entirely effective and acceptable.
Thank you. I mean, we were obviously worried about it, but we felt compelled to accept it because the cage had literally nested into that superior end plate. So. And mechanically, it seemed very strong. We did mobilize the patient with a TLSO just to protect him because of his long lever arms. But the patient went from wanting to have a cementing done to having recommendations from around the country to have a T4 to pelvis fusion done. So we did 4 levels above and 2 levels below with bicortical, very large bore screws.
Can you comment? It looks like the lumbar spine was not fully fused. The thoracic spine was, and this fracture was right through the last fused segment, is my impression.
Extremely astute observation, Bob. That was our assessment also, though intraoperatively we felt that the lumbar spine was very stiff, but radiographically, exactly what you had said was our determination also. The patient had fractured through the last fused segment, just above the non-fused segments. He had bilaterally fused SI joints also. So we could have probably fused his lumbar spine with impunity also, but we felt that in terms of surgical magnitude, and by the way, we did not have to ligate a nerve root to put this cage in. We felt that we had a very powerful fixation with this. All right, I'm gonna scoot in again.
Okay, thank you.
Yeah, fire away. You need a microphone to be heard. Over there is a microphone with Dr. Hart. Oh, yeah.
So there were recommendations to actually cement in this case?
Yes, so this physician had numerous consultations, and to some degree, this is a great example of curbside medicine. Because the initial x-ray was obtained and there was not really a formal consult written down with a formal evaluation. There were just recommendations made. They're never really formally transcribed. And then once the damage became apparent that there was a significant progressive kyphosis, the White and Punjabi instability criteria were being met, then all sorts of recommendations were held. And again, the problem with this is obviously that nobody takes responsibility for the patient from the point A, the entry point onwards, where an opinion is rendered but not formally assessed and documented, to point Z, where people say anything from, put some cement in there, it might hold, to, you got to fuse a whole spine down to the pelvis. So just wanted to underscore this case. This was a case in my UW days, a 75-year-old extremely active practicing psychiatrist. He fell, and this is not made up, 20 feet hiking, so the same injury velocity. And he was again seen, the parallels are astounding. About 2 months later, he had severe back pain whenever he got up. And basically, he was told that he had a compression fracture. And when we got an MRI and a CT scan in our clinic, we saw images that are very similar, an ankylosing spondylitis disease with a disruption of a spinal column. And you can see that the spine looks suddenly very, very different if you compare CT and MRI to the upright X-ray. So let's look for a discussant. Zach, are you willing to discuss? Oh, Dr. Hart's giving you a microphone so we can all hear you. And good morning, Dr. Landman in California and Dr. Molinari in New York. Welcome here. So how can we explain this difference from a upright X-ray? There's no trickery, okay? This is the same patient and the same time frame. What's going on there?
It seems like there's anterior and posterior ligamentous disruption, like 3-column injury.
We said 2 columns. There's no 3 columns.
2 columns.
Anterior and posterior. I overheard Dr. Gayomi talk about 3 columns also before, and I let it pass, but no more.
Likely the patient's upright and has muscle stabilization in the x-rays, and maybe when he's laying down, he no longer has this, and he clearly is some sort of translation.
I'm not totally buying that. Okay. Let's ask for more senior help. Dr. Hart, can you help Zach? He's just at the beginning of his spine fellowship. How can we explain this difference of this significantly kyphotic thoracic X-ray and then the CT and the MRI findings, which show a different finding?
Yeah, before I answer that, can we underline what you've been talking about, which was, we had there was actually a 2-column classification called the Holdsworth classification that called the vertebral body the anterior column and the posterior elements the posterior column. And then that was modified by Dr. Denis' classification, which split it into the anterior half of the vertebral body and the posterior half of the vertebral body as 2 separate columns. And he made the good point that you are much less likely to get a neurologic injury if you don't have a disruption of the posterior or the middle column, what he called the middle column. But it really ended up being a detour for spine surgeons. And the initial data suggested that there was a very high delayed neurologic compromise rate if you didn't operate on these patients and stabilize. What we now know are stable burst fractures, most of which never need surgery, right? As long as there's an intact posterior column. So it really did mislead treatment for a number of years and create a lot of anxiety among treating surgeons. I think that really underlines the importance of getting data right and verifying data, validating data, repeating data. It took probably a decade, right, before that was finally kind of recognized and realized. And I make one other point, which is the classification systems that we have. I think I really support the TLIX classification and the efforts that resulted in that. And when you look at historic classifications, it's really hard for 2 reviewers to agree that a fracture is a type A or a type B or a type C to some degree and fit it into discrete buckets of this is A, B, or C. But with TLIX, what the advantage is it's a scale. It's not a discrete classification. So you at the end of the day, one reviewer might come out with a 3, a second reviewer might come out with a 4. Well, the treatment proposed is going to be the same. And even though they're not identically labeled or identically scaled, they're close enough that the treatment ends up being the same. So this transition from classification systems to scales has been a critical improvement. And TLIX, I think, was the first classification system that really did that in trauma, or maybe in orthopedics, certainly in spine. So I just wanted to underline those 2 points. So this patient, I've got a one-word answer to your question, and the answer is gravity. So when you stand up, this cavity is not going to support you, and so he drops forward into kyphosis. When he lays down, it expands up and opens, and the alignment looks neutral on the CT and the MRI, but of course you've got that huge gap.
Bingo. Thank you. That was, first of all, much appreciated that you kind of re-emphasized the 2-column concept, which I think we can hopefully get back to. And Dr. Denise had a good reason for the 3-column concept. This was at the era of beginning CT scans, and trying to understand the holding power of the ventral column was his bona fide attempt. It was actually a way more complex and sophisticated classification system, but let's go back to 2 columns and not complicate things.
Yes, and I should underline, this was not meant in any way to demean his efforts, which I think were and did contribute to our understanding and treatment of trauma.
For me, this kind of a juxtaposition of images truly shows stability best than anything else. This is a psychiatrist, a very ornery, very critical gentleman. He makes Dr. McBride look like a soft-spoken, calm individual. No, I appreciate your critical questions. But he was very critical thinking, but he could not bear standing up. He was fine laying down. So both of those images on the right side are done laying down in the gantry. So the vertical nature is simulated, and there's a large gap that is just eroded over time. And when the patient stands up, it just basically collapses, and the patient probably kinks his cord. So this is, again, if we apply the TLIX score, a very simple math thing, morphology, I think it's a 4. We can all agree that there's not anything holding this in the front anymore. PLC, we thought, was intact. And neurologically, the patient did get myelopathy, so he could not walk anymore, and he was hyperreflexic. And we gave him the modifier 1. Modifiers are an interesting thing. That's for ankylosing spondylitis or osteoporosis. So basically, mathematically, he got a 7 score, and we basically operated on him. Now, here we did something controversial in juxtaposition to the previous case. We actually just did a posterior multi-segmental instrumentation in this largely fused spine, and we did not reconstitute the front. So you just saw the discussion of the cage placement in our preceding case, who did very well, but we put a cage in there. Dr. Hart, is this going to fail or not? We kind of recontoured the spine. We opportunistically accepted the extended position in a prone placement on the table. Is this going to fail or not? We have, I think, 4 above and 4 below.
So I think today we would probably both treat this with anterior column reconstruction, but I have very little worry looking at this construct. I'll point out for the residents, or for the fellows rather, that's one of the legacy spine implant systems. That was the first system that Synthes put out, which was called the Universal Spine System. And that was a workhorse system. And of the legacy spine implants, which was TSRH, Moss Miami from Acromed DePuy, and this system from Synthes, those were the only 3 initially available systems. This is the only one that I think still gets used, right? So it still is a very facile system, and there are still surgeons that use this not only worldwide, certainly worldwide, but in addition in the United States. And the interesting part of this is that these are not mobile head screws, right? So these are to have 4 levels of fixation above and below with fixed head screws. I'm confident that this will hold for this patient.
This is a very important point. So these are monoaxial screws. So we have to be very precise with our screw placement. Otherwise, the screws are loosened. And well said. And it was a very useful system. It was also side loading. So you could actually put the screws in and take them out around the rods. 6 months later, the fracture, and this does not project well here, but hopefully for the online viewers, this projects better, and it fully filled in. So ankylosing spondylitis heals. So back to this AO system. So anybody who comes to my office sees the 4 large posters, want to recognize the AO Spine International Group for our work in trying to get this unyieldy system applied anywhere in the spine. And basically, it still relies on A, Bs, and Cs. You've seen this slide before, but basically C is the worst case scenario where there's a completely unstable spinal column. The case that we just right now saw is probably a B3, so it's a hyperextension injury. B stands for bending. Simple bony injury is B1, and a bony injury with ligament is a B2. And the A's are basically the compressive injuries, going from a pure compression fracture all the way to a severely burst fracture, which is an A4 with both end plates, or A3 with upper end plate involvement. Pincer injuries are A2. And again, there are modifiers that we created, and these modifiers include osteoporosis, they include neurology, and they include ankylosing spondylitis. So again, very briefly now going through the names that we still use, and not just the ABCs or the TLIX score. One of the big factors is where do injuries occur? Thoracolumbar junction, 50% of all injuries. So this is a hallmark where we want to really focus on. Patients should be healthy, osteopenic, single system injuries, or are they polytraumatized patients? Remember, the rib cage is somewhat stabilizing. The conus medullaris is at this junction zone, this vulnerable junction zone of somewhere between T11 and L2. And from Paul McAfee arose a refinement of the original British discussions. And this is, again, when CT scans first became around, but all of us use these words nowadays: compression, stable burst, unstable burst, chance, flexion distraction, and fracture dislocation. We've reviewed the TLIX score, and Dr. Hart insightfully pointed out that this is actually not a classification system. This is a severity scale, which basically tries to quantify what we're talking about, and it serves as a mental checklist. Compression fractures, again, the posterior elements are intact. There's no disruption of the posterior vertebral body into the canal. And these are usually surgically not an indication, but if they're multi-level injuries, this may change. We do have to have a strong assessment of bone health in these patients. And yes, vertebroplasty and kyphoplasty may be a early intervention, although our own academy 10 years ago in a guidelines proposal said that they're not indicated. This is an arguable point nowadays, and literature may change and have to be reevaluated. A stable burst fracture exists when there's some canal compromise, but these are usually non-operative conditions. And Dr. Hart just pointed out that most of these injuries were over-operated in the past. The simplest test is getting patients upright, maybe in a brace, and seeing how they do clinically and by radiographs. What we measure is loss of height, canal occlusion, angulation, comminution, and posterior injuries. But again, that's something that we basically want to quantify. That by itself does not require surgery. The initial treatment, again, should be usually non-surgically with a brace or cast, and casts have largely fallen out of favor in this country, but are still used in many countries. This is in contradistinction to an unstable burst fracture. What makes it unstable? Anytime that there's neurology, anytime that there's a loss of body height of over 50%, we are dealing with an unstable injury. Angulations have been discussed many times. I was taught 20 degrees when I was a younger surgeon. Then it expanded towards 30 degrees. Now it's going back towards 20 degrees. I think the spine study group, the deformity section with Dr. Hart, is now looking at fractures and their impact on the spine. But if we have a truly unstable burst fracture, and we'll have an example in a second, that's something where we want to think about surgery. And flexion distraction injuries and chance injuries are frequently kind of mistaken for one another. A flexion distraction injury occurs when the ventral vertebral body is compressed, so it looks like a compression fracture. A chance injury leaves the vertebra intact and just tears them apart. So there's a posterior ligamentous disruption. And again, what we want to look for on AP x-rays is an interspinous gapping, such as seen in the top left, and posterior ligamentous disruption, such as shown by palpation, and clear pain reproduction on the part of the patient can be a helpful telltale sign, such as can be an astute observation on MRI scans or CT scans. And they are clear surgical indication. Usually a short segment fixation will be sufficient. And fracture dislocations are basically displaced in both planes and are a very clear surgical indication, usually for a multi-level reconstruction, frequently with an anterior column. Non-surgical decisions are usually made in absence of any neurology. If it's a pure bony injury, an isolated injury with an angulation less than 30 degrees and a canal compromise less than 50%, and certainly below L3, we have far more forgiveness in terms of some form of a non-surgical treatment. And for trauma patients, if there's a polytrauma, usually surgery is the preference. And again, here, posterior short segment fixation, possibly even percutaneous fixation, has a very legitimate role. We can always visit these patients later with a second stage anterior procedure. When we do acute trauma care, we don't want to have a secondary hypotension. We don't want to over-infuse patients. We want to minimize blood loss and surgery time. And again, we can always do anterior surgery later. And again, for lumbar trauma, we want to be really focusing on short segment fixation. Primary anterior surgery has become very rare. And again, multi-level posterior surgeries may be necessary with a second stage anterior procedure. So this is something where I just wanted to show 2 or 3 quick cases, and then we'll go to our final 2 cases. This is a case who came to us from Germany. It's a 43-year-old female, single system injury. Perry, this is from an institution right next to your institution in Bochum. Neurologically intact lady. She fell, I think, off a bicycle, rolled down an embankment. Single system injury. We have very incomplete images from her, but she had what, by all means, looks like a stable burst fracture. Stable burst fracture. Let me get a microphone to one of our fellows. Rick Price, maybe. Stable single level burst fracture. Assume this is, I think, L1. Based on what I just said, what is this in the AO world?
It's in the A category.
An A category, that's perfectly fine. We don't have to differentiate further. I didn't give you sagittal images. And Telix, roughly, Telix score.
Assuming no
neurology.
No posterior ligament complex disruption.
Yep.
Is it a 2 then?
It would be a 2. I would exactly say the same thing. I think we have high inter-observer liability. Dr. Hart, so your conclusion from Telix and from AO and from what I just said, what would you treat this patient with?
I mean, I'd get an MRI first because I think there's probably more to the story, but just a brace.
I'd put into a brace. I think, anybody differ? Lebanon? LA? Germany? This is what she got. She got at a university hospital an anterior posterior surgery. So she had an endoscopically placed interbody graft and posterior reconstruction. And she came to me for follow-up. She did very well, actually. No brace, but this is again one of those things where there's a cultural dimension to medicine. In Germany, most spine injuries get treated very aggressively surgically, and again in Austria and Switzerland, it's the same thing. In France also, it's a remarkable thing. Here in the U.S., it would not even be a second thought. In Canada, you'd have to be lucky to get a brace. Even there's a study from Vancouver that basically said you don't need braces. One of the classic things that the fellows have to know is that posterior short segment fixation has been associated with failures. So this is a classic board question. Posterior short segment fixation, meaning one above, one below, where you just rely on the anterior column to reconstitute, is an iffy proposition. And the same patient with, I think, well-placed screws just collapsed very rapidly, despite having been braced, and required a more extensive reconstructive surgery. So you want to be very careful when you do these short segment fixations. You don't want to over distract. You want to watch out for osteoporosis. You don't want to just rely on an absent anterior column to somehow, quote, fill in. And the non-union risk is much, much higher. So post-traumatic kyphosis is a big deal. And again, the days of anterior primary fixation are almost over. Dr. Hart, as a board examiner, if somebody came to you now with I forgot what level that is, an L1 burst fracture treated primarily anteriorly, what would you think? What would you ask the candidate?
I'm hesitating because I certainly haven't had that experience. So I think looking at this, I mean, this is a very nicely done procedure, and particularly with that graft, I mean, it really looks beautifully done. I suspect this is going to heal. I don't know what the posterior column looks like, and that part would make me nervous. So I think if you're going to do anterior column only reconstruction, you need to be very sure that you have an intact posterior column. And without that, I wouldn't trust this fixation. So I think that's where I would be focusing my examination questions.
So that's a great point. So there's clearly a overall trend towards more morbidity, especially in the acute phase. There's a higher blood loss, higher problems with pneumothorax, because we usually will violate the diaphragm on the site of the injury. So these have largely fallen out of place. It's a direct decompression and reconstruction of the primary lesion. And again, a posterior column cannot be repaired with this. This has really led towards the thought that nowadays posterior short segment fixation, possibly done percutaneously or with a very limited exposure, is actually a very legitimate option. And then when the patient is recovered, within about the first month, doing a secondary anterior reconstruction. There are those who think that this is overkill, and we saw it in the German case. But that's definitely a option, and it's a very legitimate option within the first 2 to 4 weeks. Short segment fixations usually don't fail in the very early stages. They fail at around 1 month. This leads me towards one of my 2 last cases, and then we'll go back to our 2 fellows cases. This is a patient who's neurologically intact. She fell off a tree 3 years ago. Now she had a new trauma with a car crash, with a seat back broken and all that. She's neurologically intact. She has an old kyphotic injury. And again, this is, we did not get MRIs in those days. This is a kyphosis, an older kyphosis, and there's kind of a disruption above this. So Paul, maybe shall we ask Elias? Elias, do you want to take a microphone and kind of quickly run through this based on the limited information I gave you? So there's no MRI going to be available. The MRI scanner was shut down in my hospital in those days. Yeah. Neurologically intact patient, 35-year-old healthy woman, had a remote history of a spine injury several years ago. Now she has severe back pain. She's neurologically normal.
Yeah, so this patient is at she's at a high risk of having a fracture over the apex of the curvature, mainly somewhere between T12 or T11 and L1. And I think she will have a posterior ligamental complex fracture over here, or disruption, I mean.
So posterior palpation. So what injury would this be if you use TLX, for instance? If you just run through the point scale quickly and give me an AO idea.
So you want an AO over here?
Just do a TLX. Run through the TLX.
So how is she neuro-wise?
She's totally intact.
So this is a 0. Mm-hmm. And regarding the posterior ligamental complex, I think there is a breach. This could be a 2 maybe, because we think we're
2 is indeterminate. Yeah, that's fair.
Yeah, because we're not sure yet. We need an MRI, although I can see some kind of fracture over here. And regarding the injury morphology, I'm not sure if this is a 3 or a 4.
This is the difficult one because this is an old compression fracture that basically healed, and it's probably more than an old compression fracture. So I'll tell you what we did. We classified this as a B2, but she was adamant to not have surgery, so we actually put her into a brace. Now, tell us what happened here. What do you see on this upright X-ray? So left side is an initial X-ray, and then we mobilize it with a brace. What's going on?
So this is what? This is
an upright X-ray done literally 2 days after her injury presentation in our hospital.
So
just describe what you're seeing here.
But
this is before and after.
Okay.
This is not good, right?
This is not good, but like, I think so. She had the X-ray with the brace on over here.
Yes, those are these little dots. Those are the latches for the straps.
So I think there is increase in instability for this patient, or I think she's unstable.
So in the TLX world, what would this be reclassified as? This posterior ligamentous complex. Now that you see the upright.
So we will increase it by 1 point.
Yeah. So 3 points there.
This is 3 out of 3 for the PLC variable instead of 2. And so for TLX, now she's more than 4. I think we should go for surgery.
So now let's get the microphone back to Dr. Hart. So Dr. Hart, this is one of the open questions. This patient had a pre-existing deformity, healed in a malunion. She now has a clear, significant ligamentous disruption. How do we treat this? Do we correct the deformity and treat the injury, or do we just treat the injury?
So forgive me, I'm a little unclear on the history. Is this two separate injuries? And
Yeah, so she had an old injury, a verified old injury 3 years ago. She fell out of a tree. She was treated in a brace. We don't have records from that. And then she had a severe car crash afterwards. Right. And now she has severe back pain. She is neurologically normal. And we put her into a brace. There was this question. We actually used the TLX score. We said it's a 3 at the time. And again, this is not Gazette. Some argued it was a 4. We put her into a brace. We simply got her up, and then we see this gapping.
Right.
But
right. So I think this is a combination of trauma and deformity. And you have the option here of improving her deformity as you're treating. You know, there's a necessity here for surgical treatment of the posterior ligamentous disruption, right? So now it's a little more surgery to create or to correct the kyphosis, but I think if it was me as her treating surgeon, and certainly if it was a relative, I would recommend the added intervention to correct the deformity as well.
So that's what we did. So we actually did a costotransversectomy, and we realigned the patient, and we actually had a very nice result. She was actually very pleased because she had chronic back pain. But this is one of those things, and we'll have a case. So remember this question, fracture plus deformity correction, should you do both together or not? So in summarizing my points, and we'll have Ravi come up next, so he's already coming up. Trauma outcomes are a really big deal. Neurologic integrity is preeminent. Spasticity, bowel bladder control, sexual function are at the top of the helm for patient-reported outcomes. Surgical complications throughout the bank have been reported at between 6 and 15%. I refer to the great Kirk Wood papers, and he was a previous lecture here several times. Look at our old SSF-TV trauma symposia. And what was only very poorly related to patient outcomes has been kyphosis and number of fused segments, surprisingly. With this in mind, let's have Dr. Nuna come up here and present a case of his, and then we'll close out with Dr. Price. And we have the same adapter. Thank you, Robbie.
Thank you, Dr. Chapman. Okay, great. So good morning, everyone. This is the case that we actually did over the weekend on Saturday, and I and Dr. Abdul-Jabbar performed this case. This was a 65-year-old male with a history of COPD, several decades smoking history, that presented with a 2-week history of progressive paraparesis and unremitting back pain. He endorsed that his difficulty with ambulation progressed to complete bedridden status over the course of several weeks. He did endorse decreased sensation in the lower extremities, and he denied bowel or bladder dysfunction. On physical exam, he did have weakness in the lower extremities, about 4 out of 5, worse on the right side, in addition to worsened weakness distally. He had some hyperreflexia in the right lower extremity, clonus, worse on the right side. His rectal tone was intact, and he did have a decreased sensation throughout the lower extremities, worse on the right side, in a non-dermatomal distribution. Here we see a sagittal CT and an axial CT here. And as you can see, there looks to be a neoplastic process that is invading T7, T8, and T9, most significantly the T8 vertebral body. And we can see here on the axial view that there is significant invasion of the right-sided pedicles throughout the top 2 levels there. So this is an MRI image of the same patient here. And as you can see on the left side, if it shows up well, it's a
do we need a Lee consult or?
Yeah, let me try to open this up again.
Big Sur makes a splash.
It's Big Sur, exactly.
Lee, we may need help here.
Sorry about that.
Did you push the self-destruct button?
I did, yeah.
Good man.
Okay, so we went through that. Let's try this MRI one more time here. And essentially there's highly significant critical canal stenosis at that level, very, very significant epidural cord compression at this level. Before this freezes again, I'm going to keep going. So the laboratory analysis was normal for this patient in terms of all of his lab results. CT imaging did reveal additional neoplastic lesions of unknown origin in the lung, the adrenal gland, and the pancreas. So this patient has no previous history of cancer. He generally doesn't really go to the physician for too many things, and that's why he didn't even present until his condition was very, very serious. So we did a SIN score for him, spinal instability neoplastic score. We gave him 1 point for the location, given that it was T7, T8, T9. We gave him 1 point for pain here. Obviously, there is some inter-rater variability. You know, some people might give him 3 points. Somebody else might give him 1 point. He had a lytic bone lesion for 2 points. His radiographic alignment was classified as de novo deformity or kyphosis. In this case, he had greater than 50% vertebral body collapse, and he had a unilateral posterolateral invasion. So he was scored as a 10, which is an indeterminate. 7 to 12 is indeterminate in the SIN score. So we elected to offer this gentleman surgery. Even though he had a diffusely metastatic process, this obviously was an interdisciplinary decision-making process. And we also had a palliative care consult involved, and we wanted to assess both his goals of care and how he wanted to proceed with his care. So important to him was his quality of life, regardless of his prognosis. And, you know, he was highly concerned that his neurologic compromise would worsen, unsurprisingly. So we elected to do a T4 to 12 spinal fusion with cement augmentation, as well as a T7, 8, and 9 full corpectomy. Here we have some intraoperative fluoroscopy images of our cement augmentation at the upper thoracic segments. And then here's some intraoperative fluoroscopy of the cage placement. So we did do a complete corpectomy at T7, T8, T9. The tumor had conveniently invaded most of the ribs, so the rib resection was basically already completed. And then we placed a cage that was expandable and could expand up to the necessary length for 3 levels here. Here's some post-operative imaging. Hopefully it doesn't self-destruct. But as you can see, his focal kyphosis of that segment improved from about 35 degrees to 15 degrees. And most importantly, he's had significant anterior column reconstruction in addition to complete decompression of his spinal cord. So post-operatively, this gentleman did fantastic. He was ambulatory post-op day 2. Motor exam was noted as full strength in lower extremities by post-op day 2, and his pain improved. I think moving forward for this patient, it's really going to be systemic workup, cancer workup, and quality of life concerns, as obviously this is a terminal illness, but I think at least in the short term, he's been, the proper care has been administered. Just some quick literature review. This is a recent paper out of the Spine Journal. Company-wise, this was a Globus cage. Okay. Yeah, this is a Globus expandable cage. I think we expanded it up to about 70 millimeters. Yep. So just some quick literature review. This is actually a publication out of the Spine Journal. Next month, it was published online already. This was out of an AO group, and it was looking at health-related quality outcomes following either surgery or radiation for this exact subtype of indeterminate SIN score patients. So this is an international perspective multi-center study looking at patients that were indeterminate, so SIN score between 7 and 12, so surgeon's choice essentially. And they looked at certain patient-reported outcomes, NRS, short form, and EQ-5D. This is just a quick overview of these different groups, and we can see that there are some notable differences. The functional status of the surgical cohort was worse. And then in addition, the site of the primary cancer, lung cancer was more common in the breast cancer was more common in the radiotherapy alone group, while lung cancer was actually a little less common. And then the Asia score was actually worse in the surgical cohort. Here you just see the difference in the scoring. And then ultimately the results of this analysis show that at 52 weeks, the pain scores were essentially better for the patients treated with surgery versus radiotherapy alone. So the point that this paper was trying to make was that it would appear that there seems to be 2 distinct clinical profiles for treatment of neoplastic lesions that are indeterminate, and that surgery may be the best option for a certain segment of patients.
That's great. So just thank you for that review. Can you go back to the initial CT scan? So we obviously don't want to focus on neoplasia here, although this is a very significant decision-making factor. And thank you for showing us the AO spine neoplasia study group results. If we just look at this from the TLIX phenomenon, one of the classic problems of the SINS score, which is a structural one, was the absence of neurology. If we apply the TLIX score here, the three factors, anterior column, neurology, posterior ligamentous complex, how do you rate this patient?
So in terms of his anatomy, I would give him, a complete burst fracture. So I would give him
4 points.
4 points. Okay. In terms of his PLC, I think that it's
Probably intact.
It's probably intact. And then in terms of his neurology, he's got, impending paraparesis. I'd give him
So that's 3 points right there. So that's 7 points. So for me, the problem of the SIN score, which is very helpful, is that it does not address neurology. And again, in the TLIX score, a higher point value was given to incomplete patients due to the feeling of urgency. And again, as you go forward now to the outcome study, how did neurology affect outcomes? Did you look at that?
I think I have that as one of these tables here. So they only looked at the SIN score, so they don't really look at neurology.
And that was a big. There's actually a new paper coming. There's at the bottom. You see the Asia impairment scale. So they did have neurologically incomplete patients in there, and some complete patients, none in the radiotherapy group. But that's something to still look at in terms of neurology. We want to avoid neurology in neoplastic patients especially, but in general, we want to do whatever we can to minimize neurologic embarrassment. Bob, any thoughts on this kind of a case, how it was treated, and timing of surgery?
Yeah, I don't have a lot to add. I think it's always a really difficult decision-making process with these patients, and needs. I think it needs to be done with sort of multi-specialty conferencing, particularly with oncology and internal medicine involved at the table.
But this is an important paper, and I think will be a landmark paper because it does show that surgery for an unstable spine, once it's been declared unstable with whatever accounting mechanism you want to use, right, Ravi, is better. And if you have an unstable spine, not treating it surgically is a problem. Our last case presenter is going to be Dr. Rick Price, and he has a very interesting case also.
Doing this thing again.
Lee is coming to the rescue already. So you're not on Big Sur yet. I thought it was a Big Sur interference.
I don't like change. Maybe I should.
We got to learn that trick, Lee. Thank you.
There you go. Great. Yeah, I'm Rick Price. I'm one of the spine fellows here, originally from WashU, trained in neurosurgery. This is a case of Dr. Hart's that we did about probably 6 months ago when I first started the fellowship. Kind of highlights some of the challenging decision makings that come along with ankylosing spondylitis patients with fractures. So this is a 48-year-old female. She's a history of ankylosing spondylitis and terminal heart failure, who's actually well known to our service. She presented to the hospital with 1 month of worsening bilateral thigh pain radiating from her back, and CD demonstrated a horizontally a small hairline fracture in a horizontal plane, which we'll get to in a second, at L4. She endorses bilateral low extremity paresthesias, but denies any bowel bladder dysfunction or weakness. On exam, she's neurologically intact. She's full power. Past medical history for this patient is rather significant. She has severe ankylosing spondylitis, but then severe heart failure with an EF less than 20%, hypertension, microcytic anemia, and history of stroke and morbid obesity. She's on Plavix, aspirin, and many other medications that aren't pertinent to this discussion. Additionally, she is a quarter per pack per day smoker, is unable to quit despite her medical comorbidities. So she was originally seen in her clinic in 2017. These are radiographs from that time. It's I'll get to better radiographs here in a second. You can see complete loss of lumbar lordosis, evidence of ankylosing spondylitis and scalloping of the vertebral bodies. At this time, they had a discussion about surgery for a deformity correction on her, but given her medical comorbidities, at the time her EF was 19% and she was not a surgical candidate. Actually, in the interim, she was actually placed on comfort care because of how poorly her heart functioned. She was not a transplant candidate.
You're ready for an update, Big Sur.
Yeah, I guess so. But then somehow throughout the interim, she recovered a lot of her heart function, was up ambulating again, and then came back in to our hospital with the back pain complaint. This is her current upright x-rays. You can see extensive ankylosing spondylitis, the thoracolumbar spine, complete loss of lumbar lordosis, and a large SVA. Her parameters here on the right, SVA of 18 centimeters. She's pitched forward quite a bit. She actually has a negative lumbar lordosis at negative 10 degrees. CT imaging of the spine shows that she's fused throughout posterior elements and along a lot of the anterior vertebral bodies. And then this here, just L3, 4, and 4, 5, you just see extensive arthritis here that's just kind of consumed all the posterior elements. If you look closely here, bilaterally through the posterior element, she has a fracture here on the left side, corresponds here on the right side. And that's what her main complaint was with this, we thought was causing all of her pain. Looking at her MRI here, specifically stir level, she has hyperintensity here in the posterior elements as well as in the disc space. Given her history of ankylosing spondylitis, and despite her neurology, we thought this was probably an unstable fracture just because she's fused at all the elements above and below, and she's having worsening pain upon ambulation. Additionally, I just wanted to show this. She had some stenosis at the T10-11 level as well, which went into our decision makings. So what do we do with this patient? She's medically sick. Her heart's recovered some, but she has a bad problem. So the options include TSO bracing, doing a small surgery just to treat the fracture, or do a large deformity correction. We got multiple services involved, and this was interdisciplinary discussion, including palliative care. At that time, her EF was 40%, and medically, she was cleared for surgery after Plavix was discontinued. After extensive discussion with her and her husband and her family.
Let's go back to the images. Dr. Molinari, can you activate your microphone? Are you with us? Hello, New York. Bob? Otherwise, I'll ask Dr. Landman in Beverly Hills. Todd? So Bob Molinari, can you unmute yourself? I'm sorry, I'm putting you on the spot here. If not, okay, so the big question is, do we treat the fracture only? Do we treat the deformity and the fracture? What do we do here? Or do we
They wanted to unmute me. I don't know why.
globally? Bob, can you hear us? Sorry, he's not coming on. Okay, carry on, sorry.
So ultimately, the patient elected for large deformity correction surgery. So we took her to the OR. We did this on the Jackson table with tongs. We did a hybrid surgery. Sorry, there's a lot of text. I'll get to the images here in a second. We did perk screws, T5 to 8 and L1 to 3 bilaterally. And then we did an open approach at L4 to S1. We placed screws, pedicle screws, and then dual pelvic screws. And then did a L5 pedicle subtraction osteotomy. As we were placing the interbody for the osteotomy, we encountered some brisk bleeding. Bleeding was controlled and packed off. We placed a temporary rod and aborted the case at this time. She took her to the ICU, resuscitated her, and then taken her back to the OR 3 days post-operatively from the first stage to complete the procedure. Dr. Hart does a special interbody where he custom cuts a ilium allograft to fill in the osteotomy. Then we did a T10-11 laminectomy, if you recall back, she had stenosis at that level. And then did a quad rod construct, which I'll show in a second. And then we used BMP osteostranded autograft to augment the fusion. So this was our construct. You can see here up above, where these were where the perk screws were, or domino to the lower construct down here. The outrigger rods are anchored to the pelvis with a smaller construct here that encompassed the PSO. And we had a really good correction at SVA. We brought her back to 6 centimeters and now has lumbar lordosis at 31 degrees, an improvement of about 40 degrees of lumbar lordosis. It's just a closer look of the pelvic fixation. As I said here, notice the dual iliac bolts that connected up to the higher construct.
So how did the patient do, Bob? This is absolutely beautiful. So you did the whole thing, but you did it in a kind of a segmentalized fashion. So how did the patient do, and what are your thoughts last minute?
Sure. So I would add a couple of details. I think we had placed the PERC screws at the first visit to the operating room, the towers through the skin, and as I recall, the bleeding was encountered before we were really ready to put the graft in. I don't think we'd cut the graft yet, but we're still finishing up the PSO, and it's always the last bite you take that causes the vascular injury. I've had 2 of these over the course of my career of a posterior significant vascular injury. This was venous, probably off of the iliac vein in front of the L5 vertebra or sacrum. And it's always the last bite because you stop. And we were able to get cardiovascular support here almost immediately, and we obtained hemostasis because, again, it was just a low pressure venous bleed, and the ultimate blood loss was the volume was not excessive, and she did well. I mean, we brought her back. I mean, part of that also then was that we had to break those towers off. I didn't want to remove the percutaneous screws. I saw no reason to, but we were not able to use the tower function in placement of these rods, but we were thankfully able to get the rods reduced into the screw heads without those at the second procedure. And ankylosing spondylitis, I think, is a really nice pathology, or I'll say the PERC screws are a nice technique in patients with this pathology because you don't need to gain a posterior column fusion because they're already fused. And we've had trouble. She's a delightful woman. She's actually a professional singer. Her husband is also a professional musician and travels the world. And I've been in frequent contact with him by texting, but we haven't been able to get her back for repeat x-rays yet. And so hopefully soon, but my understanding is she's doing well at home.
And one more technical question. So this looks really nice, and this is a very an inspiring case of juxtaposing fracture care, deformity correction, and neural decompression. How do you get that graft? This looks like a pretty large custom cut ilium graft. How do you get that past the nerve roots? I don't think we distracted it. It sort of just barely fit. And of course, we've taken away a lot of bone in the back, as you can see. So we were able to place it through in between the roots at 4 to 5. Great. No, this is a really cool case. So in terms of the question of deformity and fracture care, the gold standard is always to fix the fracture first and then fix the deformity because there's a higher complication rate. But in this case shows that also. This is clearly a more challenging undertaking. But sometimes we just have one shot, and this was one of those cases. So I think this is really well done. So any other insights for yourself, Rick? What would you do?
I mean, it was a very complex case. I think that this was, like you said, you only had one shot. You had to take the Hail Mary, and I think we succeeded on this. It had a rocky course going through the case, but we knew that up front. She was high risk, and per report, she's doing well. We haven't seen her back, so I think this is.
And you had a concluding slide, I think.
I just had a quick paper. I really don't need to present this. Okay. Just real quick, I guess there's this new monoclonal antibody, secukinumab, Cosentex. It's newly FDA approved to treat psoriatic arthritis and ankylosing spondylitis. The trials so far have just been for the symptoms for pain. However, they have done some MRI studies showing that the drug has been shown to decrease the inflammation in the spine. So there's a baseline that you can see inflammation T2, 3, and 7, 8. And after taking the drug in the clinical trial, the inflammation decreased. So hopefully that as patients, more and more patients are treated with ankylosing spondylitis are treated with this drug, there may be some hope for reduction in fractures and inflammation of the spine. That's all I got.
That's cool. That's a new outline. Thank you all. Thank you to our fellows. Thank you, Dr. Hart. And thank you to our visitors. And till 2 weeks from now. Take care. Good cases, guys. Thank you.
Nicely pulled together.
Sorry for the